Right. Good evening. So we are going to do the free papers discussion today. So the plan is like this. So every time when we are doing the uh, exams, so I usually do like 7, 8 free papers. So usual, this time also we'll do few free papers before you go to the exam. So this is the first paper. We'll do the rest later. So the students who couldn't attend to the class today because of the power cut and things, no worries. I will upload these videos to More Education. So you all can access the class through More Education, right? And so I'm sorry, last week I couldn't conduct that free coaching session because of some tight schedule work. So we'll do that free coaching session class on coming uh, next week. So eligible students can attend to the classes, and yeah, I will continue this class till your exams. Okay. Perfect. So we'll start the paper. Before that, another announcement. So we are going to. So the More Education is going to join with the other people to conduct the other international license exams. So I think you might be aware about that. So there are professionals are joining from USA, UK, Australia to conduct the relevant classes. So there are plenty of lecturers who are joining with us to guide our students to do these classes. So coming Saturday 5 p.m. there will be introductory class. So there are two so far. Now we have 4 resource person for the meeting. So I'll tell them who are them. So one is Dr. Aravindan from USA and Dr. Nisandini from USA, Dr. Zavidi Silva from Australia, and two more will join, one from Australia and one from UK. So the USMLE classes will be conducted by USA lecturers who are involved with the USMLE, and AMC classes will be conducted by the lecturers from Australia who are involved with the AMC exams, and PLAP exams will be conducted with the lecturers from UK. They also have quite so they are having involving with the PLAP exam. So the Saturday, please keep your time free at 5 p.m. There will be a massive introductory session, free session. So I will share the links and all. So the first class will be like they will explain about the procedures, exams, techniques, and how to get the job, and how about the job opportunities, salaries, settling in that country, and finding properties, houses, child education, everything. So not only they are conducting these classes all over the world, for every international student. So I'm just bring them to help our Sri Lankan students as well. So not only the medical students, not only RPM students, also the doctors who are working in Sri Lanka also going to join to that session. So it's going to be a massive session and massive launching by the More Education. So after that, they will start doing some free classes and guidance classes, and of course, there will be like question pools and all. So you all can easily pass the exam. They will help. In addition to that, so I'm just trying to bring them some Sri Lankans. They will help you, and then they will personally help through More Education to set your life in the other country as well. So I hope this will be useful for you. And of course, the RPM exam classes will be conducted by myself. with so many facilities. So this free session as well, I will put an exam as an exam, so you all can write, do the exams in More Education and check your marks, right? So I will upload this paper in More Education. You all can check it, and I think if you have any issues with More Education, or if you have difficulties in joining More Education exams or something accessing the classes, please let me know. I will guide you, or you can contact my coordinator. So More Education coordinator will help you. Perfect. So do you have any questions? If not, we'll start the paper. And as SLMC plan, your exam will be maybe in August and September. So I'm planning to start this mixed paper revision after, as we finish the topic-wise revision. So that will be a restreaming hybrid session, and the final one, the exam series, will be a live classes. So that is how my study plan. So meantime, this coaching session and free paper discussion will continue. Okay. So do you have any question? Dilanjana, no questions. Okay, perfect. So we'll move to the first paper. First, we'll start with the SPA, then we'll do the MCQ. So first of all, as a lot of students who attended to my class earlier, they might know how I am doing the paper class. Students who are attending first time, so this is how I do. First, when you read the question, first of all, you need to identify the key points here. So this is how we are going to do the exams. That's why we could maintain 90% pass rate. So what we have to do, first of all, we have to identify the key points. Then you have to utilize your background knowledge. You might study something about this area. So once you know that area, or once you know what they're asking, so when the examiner is asking something, you might know, right? What is the area? What is the examiner's expectation from me? What I want to know. So just use your background knowledge. Then you can go through your answers, read each and every answers, because most of the students get more wrong answers, because what they are doing is, so they are memorizing the questions, and once they see the similar kind of questions, they just mark the answers. But sometime the next year, when they have the new question or new exams, they might change a small word, or single change might change your answer. So at the time of examination, or even after finishing your exam, you might have a feeling like you have done well. Most of the questions I know, but the real situation is not like that, because they have changed a bit. That's why answer has been changed. So you don't know which one is correct. Actually, what has happened, you have lost the exam. So don't be hurry to do marks the answer. So what you have to do, first read the question carefully, identify the key points, try to understand, then utilize your background knowledge, then think rationally. Because in SBA or MCQ, especially in SBA, there could be more than two answers. One or two answers could be correct. Okay? So you have to think in a rational way which could be the correct answer. Then only you can come to the real conclusion. Right? So don't be hurried. So always you have to think twice, thrice before you select the answer. So when we are doing the question, so what we have to do is, don't come to the paper class to learn new things. This mixed paper revision, or maybe a practice exam, or maybe a free online paper discussion, everything actually not for teaching you, because these things already we have studied in theory, we have studied in revision, topic-wise revision, so we all know these things. But what are we doing in the paper revision? What is the aim of the paper revision or paper class or mixed paper revision? What we are doing is, We are just applying your knowledge to a question, to a clinical scenario. So here, rather than learning new things, you have to concentrate to know how to apply the background knowledge or how to apply your knowledge to a clinical scenario, to an exam. So that is the most thing. So whenever I'm doing a question, behind that question, there is a principle. Always you need to understand, try to understand that principle. What is the principle they are trying to ask from you? What is the principle you must know? What is the principle you might apply to the particular question? Because these terminologies might change. So this time they might put 7 years old girl, next time they might put 9 years girl. So the terminologies might change. Para 2, next time they might do para 3. So terminologies might change. That doesn't mean it is a new question, right? Because the concept is same. So in my paper class, I will try to teach you the concept rather than the question. You got the point what I'm trying to say. So don't try to learn the questions. Please try to learn the concept. Because if you really think in Obs-and-Gynae, we have set of concept. Say, for example, if it is a precocious puberty, there are few concepts they can ask in the exam. So our aim is to learn that concept. So investigations, management, types of precocious puberty. So few concepts. So if you are good in that concept, whatever the question comes in the exam, that could be new, that doesn't matter, but it's old for you. Why? Because the wordings are new, the informations are new, but the concept is same. Do you believe they can create a new concept for Obs-and-Gynae? Obviously no, right? Because there are certain concepts. So where the most of the teachers fail, they fail to teach the concept to the students. What is the reason for the success of ourselves is I'll try to teach the concept to the students. That's why even last time we had a difficult paper, we have 90% pass rate. The reason most of my students said paper is manageable. Why they could manage the paper? Because they could know the concept. So when you're coming here, please try to learn the concept rather than the subject. You got the point? Don't try to memorize the questions. So when you come to the practice exam, when you come to the mixed paper, I will teach. So just imagine, so we are doing like 6 mixed papers and 8 practice exam altogether, 14 papers and some free online papers. So like almost like 20 papers. It means thousands questions. 500 SBA and 500 MCQ. So what we are going to learn is around 500 concepts in SBA, 500 concepts in MCQ. Do you believe we are having more than 500 concepts in Obs-and-Gynae? No. So if you try to learn that concept in that course, when you go to the exam, definitely each and every question you are going to face is going to be a known question. Right? So you don't need to worry, don't get panic, right? So I'm here to help you. If you are smart enough to understand the question, then you might need less help from me. But if you are struggling to understand the question, I'm here to teach you. Right? So whoever, even if whatever how doubt you are having, please contact me. I will tell you. Even if you have any issues with joining class, just let me know. I'll help you. So ultimately, we need more doctors to the country. So unfortunate thing, Most of the doctors, most of the consultants are leaving the country now because of this economic crisis. So we are going to be in trouble maybe in 4 years, 5 years. So now we are in trouble to produce more and more doctors to the country. Right? I'm sorry. So this is the current situation. So we need to produce good doctors. So sometimes when you start working, you may have to work with low or less working force. A lot of people are moving around, moving away from the country. A lot of people are moving to Middle East. A lot of people are moving to Australia. A lot of people are moving to AMC. But that's why now I thought, okay, if people wanted to move, then I can help them, because they are struggling somewhere and they are going in the wrong way. We can guide them in a correct way. At the same time, people who wanted to stay in Sri Lanka, we have to help, and we have to make them good doctors to the country. Perfect. So we'll move to the first question. A 7-year-old girl presented with vaginal bleeding for 1 day duration. On examination, secondary sexual characteristics are present. What is the most appropriate investigation? So I would like to get some answers from you guys. So then only this class is going to be kind of interesting. Otherwise, it's very boring. So what do you think? Whoever, you don't need to tell your name. You can argue with me. You can discuss with me. You can tell me what could be the answer and we will discuss. Yeah, what is the answer? A, abdominal ultrasound scan. Okay. Any answers? Any suggestions? B, serum GnRH. Any answers, please? Okay. Any answers? Yeah, thank you. Thank you for answering. Thanks a lot. Right. Okay, perfect. So rather than telling the answer, first I will try to teach you the concept. Okay. So I will teach you how to approach this question, how to get some knowledge about this question, and how are we going to apply the background knowledge to this question. Then we'll come to the answer. So actually, when you understand the question, when you approach or when you apply your background knowledge, the answer will blink. Actually, answer will blink. You don't have much confusion. Right, perfect. So, a 7-year-old girl, that is the first information. 7 years. The age is very important. Presented with vaginal bleeding for 1 day duration. So, having vaginal bleeding in a girl, is it normal or abnormal? What do you think? Having vaginal bleeding in a girl, is it normal or abnormal? Yes, Kitma? What do you think? Is it normal or abnormal?
So it's normal but depends on the age.
Yeah, very good. So having vaginal bleeding is normal, but having bleeding at 7 years is abnormal. So that's why the gynecology, you should know the normal physiology. Having menstrual bleeding since 8 years to 55 years, in between, having vaginal bleeding is normal. But if they don't have vaginal bleeding in between this time period, age duration, it's abnormal. So deviation of physiology is gynecology. So having vaginal bleeding for a girl is normal, but having at 7 years, it's abnormal. Right? So having vaginal bleeding at 7 years, it's a bit early. So it's very early. So how do you call this condition? How do you call this condition? Having vaginal bleeding bit early. How do you call this condition? Anyone, please? Yeah? Very good. So having early menarche, no, rather than using the word early menarche, it's precocious puberty. Right? Precocious puberty. So having vaginal bleeding bit early could be a precocious puberty. So one possible cause could be a precocious puberty. Yeah, agree? So what are the other causes for early pervaginal bleeding? Anyone, please? What are the other causes for early pervaginal bleeding? One is precocious puberty. It means the puberty, it's precocious. What are the other causes for vaginal bleeding? Yeah, very good. Trauma, right? So whether it's pituitary tumor, ovarian cyst, whatever, it can cause puberty a bit early. So it's coming under precocious puberty. So puberty due to several causes. So precocious puberty is one of the cause. Other than that, other causes, one is trauma. Yeah. Anything else? Foreign body, fantastic. After. Right? So foreign body. So sometimes sexual abuse. Oh, impressing. Right? So sexual abuse, trauma, foreign body, precocious puberty, anything else? Please. One more at least. Infection. Yeah? Infection. So now even you can see how we are thinking in a rational way, right? So always you can't just straight away think about particular cause. Always you have to think what could be. When I'm reading the question, so inside the mind I have to think in this way. Okay, she's presented with pervaginal bleeding at 7 years, so it's not normal, it's abnormal. What could be the reason? So it could be a precocious puberty, it could be a vaginal or trauma, or it could be a sexual abuse, it could be a foreign body, or maybe an infection. So my question, are they going to ask about the precocious puberty, or are they going to ask about the other causes as well? So sorry, further information mentioning, like, on examination, secondary sexual characteristics are present. So secondary sexual characteristic and pervaginal bleeding, it's most likely they are concerning about the precocious puberty rather than the other causes, because they are trying to give you some additional clue about the puberty. So here the puberty, because the baby has secondary sexual characteristic and pervaginal bleeding, so obviously it's a puberty in an abnormal age. So the puberty in abnormal age. So the puberty occurred bit early. That's why it's abnormal. So it's a precocious puberty and with the secondary sexual characteristic. So now you have to think, what is this precocious puberty? What could be the reason? Now only you are going to apply your background knowledge about the precocious puberty. So they're asking, what is the most appropriate investigation? So the concept of this question is, they're asking about investigation of precocious puberty. That is the concept. So next time they could ask whatever the question, doesn't matter. The concept, they could ask this one only. So you need to understand that concept. So secondary, with a secondary sexual characteristic, baby present with precocious puberty. So what could be the reason? So what is precocious puberty? What are the possible causes? Yeah. So if you have the background knowledge, then it would be easy. Yeah. Chaturanga, what do you think? So what are the causes for precocious puberty? Yeah. Anyone, please? Hello. Hormonal imbalance. Pasan, very good. Pasan, fantastic. So precocious puberty could be a central precocious puberty or peripheral precocious puberty. It could be a central precocious puberty or peripheral precocious puberty. So what you understand by central, what you understand by peripheral? Central means when you recall your puberty, what is happening? These pubertal changes occur under influence of hypothalamus pituitary ovarian axis. When the hypothalamus secreting pulsatile GnRH, which will stimulate the pituitary to secrete FSH and LH, that FSH and LH will have impact on the ovary. So ovarian follicle will stimulate, developing follicle will release the estrogen. That estrogen will cause secondary sexual characteristic development. This is what happening in the body. So ultimately, when you look at these changes and menstrual cycle happening under hypothalamo-pituitary ovarian axis. So this hypothalamo-pituitary ovarian activity will start by 8 years, but if it is happening bit early or if it is not happening even in late, both are abnormal. When it is happening bit early, that is called precocious puberty, so bit of advanced puberty. When it is getting delayed, then we call it as amenorrhea, right? So here it's precocious puberty due to activation of hypothalamo-pituitary ovarian axis. That is one cause. Second one, due to peripheral causes. So in central causes, what are the reason for the central causes? Idiopathic. We don't know the reason. But this system has been started a bit early. Or maybe an infection to the brain, tumor, some drugs, which can stimulate. So these are causes of central one. Then peripheral precocious puberty means here there is no changes in the hypothalamo or pituitary or maybe in the ovary. Those are in inactive form. They are not started their job. But from the peripheral tissue or maybe from the outside, estrogen is entering into the bloodstream. Maybe from the adrenal gland, maybe from the outside, somebody taking exogenous estrogen. So from the outside, this estrogen is entering into the bloodstream. This estrogen can cause secondary sexual characteristic development, which can cause endometrial proliferation and shed off of endometrium. You all agree that? So ultimately in central cause, what has happened, all these secondary sexual characteristic and bleeding is due to estrogen, but that estrogen has been stimulated by GnRH, FSH and ovarian activity. But in peripheral cause, right? In peripheral cause, here the GnRH, FSH, ovarian activity not started, but the estrogen is coming from the outside. To know this, whether it's central cause, whether it's peripheral cause, what we have to do? We have to do some investigation. So what do you think? What is the investigation will find you whether it's peripheral or central? What is the investigation will help you to find whether it's peripheral or central? Yeah, of course, serum GnRH. If it is a central cause, what will happen? The GnRH level will be high because already it started to secrete. If it is a peripheral cause, this GnRH level will be low because the pituitary is not started to secrete anything. Hypothalamus is not started to secrete anything, so it's low. So depending on the GnRH level, you can narrow down your diagnosis into whether it's a peripheral or central. If it is central, so if GnRH is high, then it could be a brain mass. So then what is the next investigation? You may have to do the MRI head to check the pituitary gland. If it is a peripheral, GnRH is normal, but estrogen is high. So if you are thinking as a peripheral, then you have to exclude the adrenal mass. So then what is the investigation? What is the investigation then? Yeah? Abdominal ultrasound scan to check the abdominal mass. You got the point. So, first of all, you need to find out, or you have to narrow down whether it's peripheral or central. Then only you have to do further investigation to find out the real or actual diagnosis. So, what is the most appropriate investigation in this patient? What is the answer? What is the answer? Yeah? The serum GnRH. So, are you all clear? So, have you got this concept in this question? So, please, again and again, I'm telling, don't try to memorize the answer. That will not help you. Always, you will have to think about the concept, what they're asking. Use your background knowledge. Think rationally. Your answer will blink. Here you don't have any confusion. Right, perfect. So shall we move to question number 2? Question number 2, a 14-year-old girl presented with delay in menstruation. Yeah. So the first question is early menstruation. Now it's delay in menstruation. So I told you, if somebody attained menarche before 8 years, it's abnormal. If after 14 years or after 16 years with secondary sexual characteristic, that is abnormal. That is called primary amenorrhea. So a 14-year-old girl presented with delay in menstruation. She's 14 years, but still she does not have menstrual bleeding. So it's not normal. She has recent history of cyclical lower abdominal pain. Breast development is normal. What is the most likely cause? Yeah, what is the most likely cause? Yeah, please tell the answer, then I will teach you how to approach this question. Constitutional delay, Turner syndrome, transvaginal septum. Okay. Thank you so much for the answers. Okay. Thank you. Right. A lot of people are answering. Fantastic. Thank you very much. So let me to explain this one simply. Give me one sec here. Okay, perfect. Now, this is your uterus. So I'm very poor with drawing, so please bear with me. So this is the vagina. You are having vaginal opening somewhere here, right? So usually vaginal opening will be covered with a membrane called hymen. There could be a small opening in the hymen membrane. This is the cervical opening. You are having an endometrial cavity. Your fallopian tubes. The ovary. Perfect. So this ovary under influence of hypothalamus and pituitary, finally the ovary. So in addition to that, there are other hormones which play a role in menstruation and ovulation are thyroid, prolactin, and insulin. Perfect. Now, what is happening, as I told you a bit early, from the hypothalamus, GnRH is secreting. This GnRH will act on the pituitary. This pituitary will release FSH. That FSH will act on the ovary. So ovary will release estrogen. At the same time, the egg will develop. That estrogen will have two effects. One is it has the effect on the endometrium, and it has the effect on the secondary sexual characteristic, other hormone, breast development, the labia majora, labia minora, feminization, female appearance development, all the secondary sexual characteristic development. So now you can see, ultimately all these kind of development under influence of estrogen. So this estrogen will be secreted from the ovary under influence of FSH and LH. So FSH secretion under influence of GnRH from the pituitary. Right? GnRH from the pituitary. So this is how the female reproductive system works. So here you can see there are hormones which are controlling the female reproductive system. These are gonadal and sex hormones. Same time, in addition to that, there are other hormones which has implications on this female genital tract, the thyroid, prolactin, and insulin. Thyroid, prolactin, insulin can inhibit or alter the ovulation or ovum development. Okay, perfect. Now, here, when a woman attains menarche, what is happening? The GnRH, pituitary, will secrete in a pulsatile manner. So, under influence of pulsatile GnRH secretion, hypothalamus will secrete pulsatile GnRH. Under influence of pulsatile GnRH secretion, FSH will release from pituitary. The FSH will act on the estrogen. Estrogen will cause endometrial proliferation and secondary sexual characteristics. So, if you have any issues in this hypothalamo-pituitary ovarian axis, so if you have any issues in the hypothalamo-pituitary ovarian axis, or if you have an effect due to these hormones, which can stop the ovum development. So if the GnRH is not secreting, or FSH not release, or maybe ovary not respond to this FSH or LH, the follicle will not stimulate. If follicle not stimulate, what will happen? Estrogen will not release. Without estrogen, can you have endometrial proliferation? No. Can you have secondary sexual characteristic? No. So, if you have an issues in hypothalamo-pituitary ovarian axis, that woman will not have estrogen, so that woman will not start menstruating. She will not have menstruation. So obviously it's going to be amenorrhea due to failure of hypothalamo-pituitary ovarian axis. Agree that? She's not menstruating because hypothalamo-pituitary ovarian axis not working. So there is no estrogen. Without estrogen, no endometrial proliferation. So no bleeding. So she couldn't bleed because there is no estrogen. So in addition to that, this estrogen, as I told you, it's needed for the secondary sexual characteristic. So here, this girl does not have estrogen. So without estrogen, can she have secondary sexual characteristic? What do you think? Can she have secondary sexual characteristic? Yes or no? Yeah? No. So definitely secondary sexual characteristic also will not be there. So this lady will present it with absence of menstruation or primary amenorrhea without secondary sexual characteristics. You got the point? So if a woman presented with Primary amenorrhea without secondary sexual characteristic means immediately you have to think, what is the principle here? So immediately you have to think, this should be a problem in hypothalamo-pituitary ovarian axis. There is no estrogen. That's why she does not have bleeding and secondary sexual characteristic. You got the point? Right? So this is one reason. So patient or woman with without secondary sexual characteristic and primary amenorrhea, it should be a problem with the ovum development. There is no estrogen. Second condition, now she's having estrogen. So when she has estrogen, obviously secondary sexual characteristic will be present. Yeah. Of course, this secondary sexual characteristic will present, because if secondary sexual characteristic is present, maybe a GnRH, FSH, LH is there, and ovary is secreting, and ovary is functioning, secreting estrogen is there, her secondary sexual characteristic is developing, but still she is not bleeding. So it means there could be problem in the endometrium, or could be problem in the passage, because when the endometrium shadow, with the endometrium, blood will come through this passage, through the endometrial cavity, cervical canal, vagina, vaginal opening, and ultimately it will come out. So if you have any blockage in this passage, outflow tract obstruction. If a woman does not have endometrium, even though estrogen present, she can't have endometrial proliferation, she can't have bleeding, so definitely she will not have bleeding. Or sometimes that woman might have uterus and endometrium, but the blood is not coming out because the outflow tract has been obstructed. So in this kind of woman, the estrogen is there, so secondary sexual characteristic is present, but the problem is with the uterus or outflow tract. So sometimes some woman might not have uterus, absence of uterus. Can you just tell me the condition where the uterus is absent? Please. Anyone? It's a hot topic. Always we get MCQs in SBA. Major occupancy Kuster-Host syndrome. Oh, other name? Mullerian agenesis. Right? Mullerian agenesis. So in Mullerian agenesis, the Mullerian duct is not developing. So Mullerian duct is the one developed as uterus. So Mullerian agenesis. Mullerian duct is not developed. So uterus is not developed. Obviously she has ovary, but there is no uterus. So without uterus, can she have bleeding? Can she have endometrium? Can she have bleeding? Yeah. So she will not have bleeding, but she's having ovary, she's having ovulation, she's having estrogen, so she will have secondary sexual characteristic. So if the uterus is present, if bleeding is not there, then it could be an outflow tract obstruction. So obstruction could be in different level. Obstruction could be in different levels. So obstruction could be in the cervical, so uterine, so transverse uterine septum, cervical stenosis, transverse vaginal septum, imperforated hymen. So here what will happen? So the flow will get obstructed. So the flow is getting obstructed here, some here. So depending on the level of obstruction, the menstrual bleeding is going to accumulate just above that, isn't it? So for example, if it is a cervical stenosis or transverse uterine septum, so then the menstrual bleeding is going to accumulate here. So she is not bleeding, but when you do the ultrasound scan, you can see some collection of fluid inside the uterine cavity. How do you call that? That is called hematometron. Hematometron. When there is a septums in the vagina, or maybe in the vaginal opening, imperforated hymen, the blood is going to accumulate inside the vagina. How do you call that? That is called hematocolpus. Colpus means vagina. Metron means uterus. So in this woman, if it is secondary sexual characteristic present with primary amenorrhea, always you have to do the ultrasound scan to check whether uterus is present or not. If uterus absent, then it's MIS. If the uterus is present, then it could be due to outflow tract obstruction. So in that case, you can check where is the collected blood, whether it's in the endometrial cavity, whether it's in the vagina. You can see whether it's hematometron or hematocolpus. So I hope you might understand what I have explained. Now we'll come back to the question again. So 14-year-old girl presented with delay in menstruation. She has recent history of cyclical lower abdominal pain. Breast development is normal. What is the most likely cause? So here, she's delaying menstruation with secondary sexual characteristic, means her ovary is normal, her estrogen is okay, but she's not getting bleeding. But another point they have mentioned, cyclical abdominal pain. What is the meaning of that? Her endometrium is shedding off, because every woman, when they are having menstrual cycle, they have pain. So she's not having bleeding, but she's having pain in a cyclical manner. So it means she's menstruating inside, but it's not coming out. It's got stuck somewhere. So somewhere it's blocked. That's why she's getting cyclical pain, but she couldn't reveal the bleeding. So what could be the reason? Ovarian resistance syndrome. Of course, they can have secondary sexual characteristic, but there is no problem with the outflow tract. So they should have bleeding. So it's out. Transverse vaginal septum, of course, it's an outflow tract obstruction. Testicular feminization syndrome. In testicular feminization syndrome, there is no uterus, because that is a male. Constitutional delay. Yeah, that could be, but how can we explain cyclical pain? See, a word, it's very important for you to come to the answer. Turner syndrome. In Turner syndrome, problem is in the ovary. Ovary does not have follicle. So if the ovary does not have follicle, can you have follicular development? Tell me, can you have follicular development? No. Without follicular development, can you have secondary estrogen? Can you have? No. Without estrogen, can you have secondary sexual characteristic? No. So could it be a Turner syndrome here? What do you think? Could it be a Turner syndrome? So now, once you understand the subject and you understand the question, you should be able to tell the explanation of each and every stem. You got the point? Each and every stem, you can simply tell the explanation. What could be, why it is. So answer for question number 2 is B. So hope you might understand. So I'm taking some time to explain the question, because this is not the time matter. This is the matter of explanation. Without knowing the answers or without knowing the question, no point of. So I can quickly read the question and tell the answer. Useless. Because until you get the same question, you will not able to do the question at the exam. So if I am explaining this one, so if you get a question, similar type of question or similar concept question, you can simply answer. So very careful. So, and again, I'm reminding you, so those 2 things, one is we are starting the mixed paper revision by next week, and second, the most important thing, we are having the introductory course for international license exams AMC, USMLE, PLAP with the resource person from USA, two teachers from USA and two teachers from Australia and one from UK. So we are going to do a massive starting. So please share this message. So I will share the meeting link and all everything with you in this group. So please share this information with your friends and your seniors who are willing to do those license exams this difficult time. So we will help them, right? So please pass this message. What about the activation of phones? Yeah, of course, we will do that. So all these free classes you can access through the phone as well. Only for the paid classes through the Maura only you need the phone app. So I'll give you soon, because now we are starting this international exam, because those teachers who are conducting the classes already for the international students, not only Sri Lankan. So I have had a chat with them to bring them to the Sri Lankans to do these classes. So I think it will be useful for our students. So we will conduct the classes for our students as well. So I think it would be useful. So, and I also will join for the Obgyn Gynae part for those license exams. So the rest of the part and the clinicals and practical sessions. So how then these days due to COVID, they are doing the online clinicals. So they will do the clinical scenarios and clinical part as well. So the part every license exam has clinical slots. So then they will teach you the clinical session as well. So I asked them to do free classes these days because of these crises. So they will do free classes. So you can join. So even you can go to the exam with those free classes as well. And if you like, you can join to their classes. They are conducting already, so you can. But I just want to introduce them to you. So there will be a massive introduction for our ERPM students and the previous ERPM students. Currently are working as a doctors, and local medical students and local doctors. Everyone can join and plan out their future. Same times, the students who are willing to stay with us to save the country, yeah, I'm here to guide you for your ERPM. Okay, perfect. Question 3. A multigravida patient with breech presentation in second stage of labor for 2 hours. The heart rate, fetal heart rate is 140. The pelvis is adequate. What is the most appropriate management? Multigravida, breech presentation, second stage of labor 2 hours, fetal heart rate 140, pelvis is adequate. What is the most appropriate management? Yeah, anybody please answer, please. Yeah, Lakshi, what is the answer? Watch for another 1 hour. A, apply peanut manovir to deliver the fetal limb. Right. Infusion of syndesinone. Is that answer is there? Yeah, of comments infusion and syndesinone. Yeah, D. Okay, perfect. Right. Now, okay, again, I'm going to teach you the concept on this question. So that is the most important part, to know about the concept rather than, learning these answers. Okay. A multigravida, second stage of labor for 2 hours. Is it normal or abnormal? That is the first thing. So these are the important information. Multigravida, breech presentation, second stage 2 hours. For multigravida, what is the duration of second stage? What is the duration of second stage? 1 hour. Very good, Dulanjala. It's 1 hour. So now the second stage of labor, it's 2 hours. So what do you think? Is it normal or abnormal? Normal or abnormal? Abnormal. So how do you call this one? Prolonged second stage. Because it's already 2 hours. You are supposed to wait for 1 hour. Now it's 2 hours. So prolonged second stage. So if a labor is getting prolonged, what could be the reason? What are the reasons for prolonged labor, either first stage or second stage? What could be the reason? Anyone? So now when I'm teaching this background knowledge, you have to recall it. So if you can't recall or if you forget, so you have enough time, please go and watch those Maura videos. Now probably by end of this month or maybe a first week of June, I will upload my all recorded the standard videos in a fresh videos. You all can study very nicely. So please, very good, Tulangela. So problem could be in passenger or passage or maybe in power. So if it is delayed labor, could be problem in the passenger, could be problem in the passage, could be problem in the passage power. So among these three P's, passenger, passage, power, which one is more common? Which one is more common? Power. Fantastic, power. So always the power is the most common one. So there could be inadequate contraction. Yeah, possible. What is the problem or what could be the reason for the passenger? Abnormal presentation, abnormal lie, maybe macrosomic baby, very good, large baby, right? So that is passenger. So here, the breech presentation, is it a normal presentation or abnormal presentation? Breech, abnormal. So one of the reasons for this prolonged second stage is the breech presentation, abnormal presentation. Are you all agree with that? Perfect. Perfect. So the breech presentation could be a reason for prolonged second stage. Already you have waited for 2 hours. So if it is a cephalic presentation prolonged, then what is your management? You could do instrumental delivery and take the baby out. You can expedite the delivery with the help of instruments. But here, can you apply instruments for this patient? No, because it's breech presentation. Already 2 hours gone, but they haven't mentioned anything about the number of contraction. So in that case, are you willing to start syntocinon and wait for another 1 hour? No, because already 2 hours gone. It's a multi-mother, adequate pelvis. In spite of adequate pelvis, in spite of contraction, she couldn't do. They haven't mentioned how many contractions, but she didn't deliver for 2 hours. It's prolonged, so there is no point of waiting and starting syntocinon. It might harm the baby because already you have waited for another additional 1 hour. So you can't put an instrument. There is no place for the syntocinon. So can you pull the baby and take it out? That is called breech extraction. Can you do that? No, because for singleton breech presentation, breech extraction is not recommended because that space is not enough. Only you can pull the baby out if it is prolonged, if it is delivery of the second twin in twin pregnancy. Already first baby delivered. If it is a second baby got delay or any urgency, you can put your hands inside and pull the baby's leg and pull it out. That's it. That is called internal podalic version and breech extraction. But for the singleton baby, breech extractions are not recommended. But if the breech is normally delivering, then you can do Manovers, your Pinard Manovia, Lovset Manovia, Morris Melly Manovia, whatever. If it is just breech delivery, you can assist. Here, breech is not delivering. It's getting delayed. You couldn't put an instrument. There is no place of oxytocin. You couldn't do a breech extraction, somehow you need to take the baby out because already you are delaying. So what is the next option to take the baby out? You have to find another option. The vaginal delivery, is it possible for this mother? No. So we have to go for a section. So see how you can apply the principle for this question. So the concept. So first of all, you need to know what is the duration of second stage for the primary. Second, you need to know whether you can apply instrumental delivery, whether you can do breech extraction for a singleton breech. If not, what is the management option? See, this is the principle. Can you wait for another 1 more hour? This is not ERPM exam to wait without any reason for a long period, isn't it? So if it is 1 hour, it's allocated, you have waited for 2 hours, so there is no place of, no, there is not recommended, because when the baby is in second stage for a long time, which can cause hypoxia to the baby. So we need to do the cesarean section. Clear? Perfect. So now you all can understand how we are doing the papers. So without knowing this explanation, no point of doing examination questions. Right. Question number 4. A 35-year-old woman with previous history of spontaneous vaginal delivery followed by 2 cesarean sections for breech babies attended the clinic to discuss the delivery of 4th child. If the baby is cephalic at term, she would like to try for vaginal delivery. During your counseling, you mentioned the risk factors for the uterine rupture during VBAC. Which of the following option does not increase the risk of uterine rupture? Actually, it's a straightforward question. They're asking, or they are assessing your background knowledge, but they are giving some scenario to understand about that. So 35 years, the age. So increasing age is unfavorable factor for vaginal delivery, and risk of uterine rupture is bit high with increasing age. That is one. Yeah, agree? Because with increasing age, the contractility of the uterus will reduce. Rigidity of the uterine muscle will increase and it can easily rupture. Yeah, that's possible. Previous 1 vaginal delivery and 2 cesarean sections. So when somebody have 1 cesarean section, risk of uterine rupture is 0.5%. When it is 2 cesarean section, the risk of uterine rupture is 1.6%. So it bit increasing because she has 2 times scarred uterus. So the risk of uterine rupture is bit higher than singleton pregnancy. So obviously, this lady has more risk of uterine rupture than 1 previous cesarean section. Are you all agree that? If somebody have 1 previous cesarean section, the risk of uterine rupture is bit less than this lady because she had 2 cesarean section. Agree that? Perfect. Thank you. So she has a history of previous vaginal delivery. So this is a favorable feature for vaginal delivery. If somebody have previous vaginal delivery, that is the single most favorable factor for VBAC. When somebody have vaginal delivery in previous birth, even though she has cesarean section in current pregnancy or previous pregnancy, this current pregnancy, successfulness of VBAC is bit high. A woman who is going for a VBAC, what is VBAC? Vaginal birth after cesarean section. A woman go for a VBAC, vaginal birth after cesarean section, what is the success rate? Success rate is around 75%. But if that particular woman has previous vaginal delivery in addition to the cesarean section, the success rate will increase to 90%. You got the point. the success rate will increase to 90%. So uterine rupture risk is bit high with previous two cesarean section. So what are the risk factors? So what are the factors will not increase the risk of uterine rupture? Preterm labor. What do you think? If it is a preterm labor, the baby is smaller. The lower segment will not form. Your scar tissue is mainly in the lower segment, not in the upper segment. So your lower segment is not that much thin. It's a bit of thick because it's preterm. So ability of rupture is less. So if it is a preterm labor, risk of uterine rupture is less when compared to term baby. Short inter-delivery interval. What do you think? Of course, because minimal inter-deliveries should be 2 years, because you need some time for the healing of scar, the fibrous tissue formation. So if somebody have become pregnant very, very quicker, then what will happen? The lower segment will not be, stronger, which can easily get ruptured. Okay? So shorter inter-delivery interval, yeah, that's true. 2 or more previous cesarean section. Yeah, I told you, when compared to 1, 2 or more, the risk is bit high. Induction of labor, yes. When you make the uterus to contract forcefully, then uterine rupture is high. Fetal macrosomia, what do you think? Yeah, because the baby is large, uterus stretch more, which can easily rupture the uterus. So preterm labor, it's not increasing the risk of uterine rupture when compared to others. So answer is A. Perfect. Do you have any question? No. Thank you. Question number 5. A 48-year-old woman with irregular vaginal bleeding underwent dilatation and curettage. Histology report as complex glandular hyperplasia with atypia. The best management option. What is the management? Answer, please. Yes, Kitma, you're correct. Any answers? Total abdominal hysterectomy. Yes, Abhirami, yes, you're correct. Okay, thank you. So we'll discuss this question. A 48-year-old woman. So her age is 48. That is the most important fact here. Age is 48. Perimenopausal age. A perimenopausal age woman with irregular heavy menstrual bleeding, always we need to exclude the malignancy. There is a possibility of endometrial cancer. So she's 48 with irregular heavy vaginal bleeding. So this is our duty to exclude the malignancy. So how to exclude the malignancy? By taking a biopsy. So they have done dilatation and curettage for the biopsy. Now the biopsy report came as complex glandular hyperplasia with atypia. What do you mean that? What is complex glandular hyperplasia with atypia? Yeah, anyone? What is this? Single word? Can anybody say single word answer for this? What is this complex atypical hyperplasia? No, it's not malignant. It's not cancer. It's not malignant. It's not cancer. Sin. Sin means cervical. Madam, this is endometrium. So not cervical. What is this? Very good. This is pre-malignant. So the normal endometrium, hyperplasia. What do you mean by hyperplasia? Proliferating more. Normal endometrium proliferating more. When it is proliferating more, what will happen? The structure, the genetic control might alter. When it is proliferating more and more, there is high chance of having abnormalities in the gene, changes in the gene, which can convert into malignant. You got the point? So normally cells are proliferating. Now it's hyperproliferation. When it is hyperproliferation, risk of malignant transformation is a bit high, but still it's not malignant. It's excessive proliferation. So that's why we call it as hyperplasia. This is pre-malignant. So normal cells, hyperplastic cells, malignant cells. So it is not normal cell, it is not malignant, it's hyperplastic, in between, pre-malignant, still not malignant, it's pre-malignant. These pre-malignant cells could be two types. One is pre-malignant cells without ATPR, pre-malignant cells with ATPR. What do you understand by that? So pre-malignant cells without ATPR means atypical. Typical. These are the words. What is typical? Typical means same as normal cells. Atypical means appearance is not like the normal, but genetic type is normal. It's not changed as malignant, but the appearance is started to change as abnormal. So it means now you can say normal cell, hyperplasia without atypical cells. Then when it is becoming with more abnormal, hyperplasia with atypical cells, those abnormalities will easily convert as malignant. You got the point? So it's a step-by-step process. Normal cell, hyperplasia without atypical cells, hyperplasia with atypical cell, and malignant cells. So this hyperplastic cell with or without ATPR, it's pre-malignant. But when compared to atypical cells, typical cell has less malignant potential. You got the point? So when we are talking the malignant potential, normal cell first, then normal cell, typical hyperplasia is bit high, atypical hyperplasia is more high, then finally malignant cell. Complex mean you can have both kind of typical and atypical hyperplastic, both cells. So ultimately this mother is having atypical hyperplastic cells. So it means it's more abnormal towards malignant. Risk of malignancy with atypical hyperplasia in 20 years is 20 to 50%. Around 50% of mothers will become malignant within 20 years. Around 42% of mothers might have associated cancer with atypical cells. So it means the risk of malignancy or coexisting malignancy is very high with atypical hyperplasia. But typical hyperplasia, risk of developing into malignancy is 5% in 20 years. So it's less. So now you can understand the risk of developing malignancy of typical hyperplasia and atypical hyperplasia. So if it is an atypical, so typical hyperplasia, still the risk of malignancy is only 5% in 20 years. If you let this endometrium to proliferate in hyperplastic manner, if it is continued to proliferate more and more, then 5% of mothers will develop into malignant in 20 years. So the treatment, you don't need to take the uterus out, you can stop the proliferation. Yes or no? If you stop the proliferation, the transformation can stop. So how can you stop the proliferation? By giving progesterone. Progesterone will make the endometrium atrophied. So either you can give oral progesterone or you can give local progesterone with Mirena coil. So if it is a typical hyperplasia, treatment is progesterone. But if it is an atypical hyperplasia, almost 50% of mothers might have coexisting malignancy, or 50% will develop malignancy in 20 years, the risk of malignancy is high, then we are not going to treat them with medically. To minimize the risk of malignancy, take the uterus out. So if it is an atypical hyperplasia, always the management is hysterectomy. If it is a typical hyperplasia, you can do medical management, see whether she is responding to progesterone. If she is not responding to progesterone, if she is continue to progress, then you can take the uterus out. So here, the histology report has complex glandular hyperplasia with atypia. So it's an atypical hyperplasia. So the risk of malignancy is a bit high. So you have to remove the uterus. Total abdominal hysterectomy will be the answer. Question number 6, a 38-year-old multiparous woman presented with menorrhagia. She presented with menorrhagia, dysmenorrhea, which outlasts the period. It means what you understand by outlast the period is even after stopping the period, her pain is outlasting. So her pain is existing. Abdominal, vaginal examination revealed a uniformly enlarged uterus corresponding to the size of 14 weeks pregnancy. Ultrasound scan revealed a uniformly enlarged uterus with marked myometrial thickness. No other pelvic pathology. Her recent cervical smear was normal. What is the most appropriate treatment? What is the answer? Myomectomy, THBSO, hysteroscopic resection of endometrium. Oh my God. Okay, what is the diagnosis? What is the diagnosis? Fantastic, it's adenomyosis. What is adenomyosis? What is adenomyosis? Anyone? Yeah, Pasan, what is adenomyosis? Yeah, Pasan, what is adenomyosis?
Endometrial tissues within the myometrium.
Fantastic. Yes, thank you so much. Fantastic. So, presence of endometrium into the myometrium. Okay, presence of endometrium into the myometrium. Right. So this is your uterine cavity. This is your endometrial cavity. This is your myometrium. So here the endometrium will line the endometrial cavity. And during the menstrual cycle, this endometrial tissue will proliferate and shed off and come out. This is how it's happening. So sometimes due to some reason, maybe a cesarean section when you damage, or myomectomy when you damage, or maybe during the childbirth when the uterus is getting stretched, so this junction might get weak. This endometrium might enter into the myometrium. So this endometrial tissue might present in the myometrium. When it is present in the myometrium, during the menstrual cycle, when the estrogen is secreted, under influence of estrogen, these myometrial tissues will start to proliferate. So now another tissue is proliferating in between the muscle cells. So during the menstrual cycle, this endometrium will shed off and start to bleed. So what will happen? The bleeding into the muscles will stretch the muscle fibers. So patient will have severe pain during the menstruation. That is called dysmenorrhea. When the uterus is getting distant and getting inflamed, so now these muscles are getting inflamed, and when the muscles are getting inflamed, the vascularity of the muscles will increase. Inflammation can cause fibrous tissue formation, and uterus is getting enlarged. So Now the uterine size is enlarging. Myometrium, it's getting enlarged, thickened myometrium. Hypervascularity. Uterine muscle fibers will replace by the fibrous tissue in spite of increasing vascularity. So in addition to the increasing vascularity, muscle contracting ability reduce. So then what will happen? During the menstruation, uterus will not contract. Blood will get more blood to the myometrium, start to bleed a lot. So they will have menorrhagia, bleeding is less high. Menorrhagia with severe painful menstruation, that is called dysmenorrhea. So menorrhagia, dysmenorrhea, enlarged uterus, thickened myometrium. What is your diagnosis? That is called adenomyosis. So if it is an adenomyosis, here, if it is a fibroid, you can see a localized thickness. You can inoculate and take the fibroid out. But in adenomyosis, there is no localized thickness. It's a diffuse thickness. It is diffuse thickness. When it is diffuse thickness, you can't resect as the fibroid. So myomectomy, it's not possible option. So the definitive management for the adenomyosis is take the entire uterus out, otherwise she will have pain, she will have bleeding. Yeah, the hysterectomy would be the best option. But if patient wanted to preserve uterus, or if you are not happy to take the uterus out, you can suppress the endometrium. So then endometrium will not proliferate, endometrium will not bleed, endometrium will not cause pain. So you can suppress the endometrium. How can you suppress the endometrium? What is the drug will suppress the endometrium? Yes. What is the drug will suppress the endometrium? Progesterone. Progesterone will suppress the endometrium. So you can give progesterone, either oral progesterone or local progesterone with LNGIUS. You can put a Mirena coil device inside the uterine cavity that will release the progesterone. That progesterone will suppress the endometrium, so they will not have much bleeding, they will not have much pain. So those are the treatment options for this condition. So here what they are asking is 38-year-old multiparous woman presented with menorrhagia, dysmenorrhea, outlast period, abdominal pain and vaginal examination reveal uniformly enlarged uterus. Ultrasound scan reveal uniformly enlarged uterus, marked myometrial thickness. It's an adenomyosis. No pelvic pathology. Recent cervical CNO. What is the most appropriate treatment? Appropriate treatment. So here, if they give like LNGIUS, that would be the most appropriate because she's 38, quite young. Going for a uterine removal, it's not an appropriate option for young patient. So you can treat her with medically. If failed, you can go for a surgical management. So here there is no LNGIUS, so TAH. No need to remove the ovary, only uterus is enough. You can do the hysterectomy. But if it is 48-year-old adenomyosis with pain, then you can go for a surgical option because considering her age, here she is 38, so quite young. So you don't need to go for a hysterectomy. You can go for a medical management. But if they ask what is the definitive management? Definitive management, progesterone is not a definitive management. Definitive management is hysterectomy. Here they have asked about the appropriate management. This terminology is very important. So appropriate management could be LNGIUS, or could be TAH. So here there is no LNGIUS, so that's why I select TAH, not the THBS. So answer D. Shall we move to MCQ? The MCQ first question, COCP reduce the incidence of. So it's a straightforward question. When you use COCP, this COCP will have non-contraceptive benefits, right? Non-contraceptive benefits. Not only contraception, also this COCP will have a lot of benefits like reducing the bleeding, reducing the pain, regularize the bleeding, reducing the risk of PID, reduce the risk of ovarian CA, reduce the risk of endometrial CA, reduce the risk of PID, reduce the risk of colonic CA, reduce the risk of duodenal ulcer. So this COCP is a marvelous drug which can cause so many advantages, right? So here COCP reduce the incidence of breast cancer. Breast cancer risk is a bit high when somebody use COCP for 10 years. So it's not reduced, it's increasing, it's false. Ovarian cancer, yeah, of course, it's true, because when you are using COCP, the COCP will stop the ovulation, so ovum will not release. Whenever ovum release, what will happen? The surface epithelium of the endometrium, so ovary, will rupture and ovum will release into the endometrium or peritoneal cavity. So every time when the ovulation occurs, surface epithelium will rupture and release, rupture and release, rupture and release, rupture and release. So multiple epithelial damage and proliferation, damage, proliferation, damage, proliferation. You have more and more proliferation. If you have more proliferation, that is risk for the malignancy. So whenever she ovulate, there is a risk of malignancy. But when you use OCP, you are stopping the ovulation, so will not release, so will not rupture, will not proliferate, so risk of ovarian CA is less. So ovarian CA risk is bit less, that's true. Cervical cancer, of course, ovarian CA does not have effect in the cervical cancer. It's not reduced, false. Primary amenorrhea, no, it's false. There is no evidence of primary amenorrhea, because already we have discussed about primary amenorrhea. There is nothing. Ectopic pregnancy, that's false. Keep it in your mind. Not only COCP, all the contraceptive device will reduce the chance of all pregnancies, either intrauterine, either ectopic, whatever. All pregnancy chance is less. But when somebody on intrauterine contraception, such as copper device or LNGIUS, so the foreign body in the uterine cavity. So while the foreign body in the uterine cavity, if contraception failed, if she become pregnant, then risk of ectopic is bit high, because some foreign body in the endometrial cavity, so baby will not come to the endometrium, baby might stay in the tube. So risk of ectopic with failed IUCD is 5%, bit high. But all the contraceptive device will reduce all type of pregnancy. So false, true, false, 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 true. So ectopic pregnancy risk is reduced, true, that's true. So false, true, false, false, true. Right. Question number 2, causes of post-coital bleeding. What do you understand by post-coital bleeding? What you understand by post-coital bleeding? What is post-coital bleeding? What is post-coital bleeding? Very good. Bleeding after intercourse. So if somebody have bleeding after the intercourse, means where could be the pathology? Where could be the pathology? Somebody is having bleeding after the intercourse. So where could be the pathology? Maybe, very good, maybe a pathology in the cervix, or maybe pathology in the vagina. So maybe cervical ectropion, cervical cancer, cervical infection, or vaginal infection, vaginal cancer, or atrophied vagina with an atrophy. When a penis go inside, it might cause friction, damage to the epithelium, and can cause bleeding. So if you think that, you don't need to remember anything. Or maybe foreign body in the vagina, yeah? So can cause bleeding. So adenomyosis, can it cause postcoital bleeding? Adenomyosis, can it cause postcoital bleeding? So in adenomyosis, where is the pathology? Where is the problem? We have discussed. Where is the problem? Here? Very good. In the uterus. So can somebody have bleeding? So during the sexual intercourse, are we dealing with the uterus? And then it's not sexual intercourse, right? So we are just having contact with the uterus, cervix and the vagina. So can't cause bleeding from the uterus. It's false. Atrophic vaginitis. Yeah, that's true. Because atrophic vagina, maybe friction can cause, that's true. Cervical ectropion. The highly vascular columnar epithelium is exposing outside. So when the penis touch that columnar epithelium, yeah, they can have bleeding. Cervical ectropion, yeah, that's true. Granular cells, granulosa cell tumor. Yeah, you can get the granulosa cell tumor. Yeah. What is the organ has granulosa cell tumor? Cervix, vagina, uterus, ovary, fallopian tube. Where? In the ovary. So if you have a tumor in the ovary, will you have bleeding when you are having a sexual intercourse? Can you? Even though this granulosa cell tumor secrete estrogen, estrogen does not have causing bleeding in the cervix or vagina. So granulosa cell tumor falls. Subserosal fibroid. If you can cause bleeding for the subserosal fibroid with the sexual intercourse, then there should be a vaginal tear and the penis should be in the peritoneal cavity, isn't it? So the subserosal fibroid is in the abdominal cavity. Even subserosal fibroid can't cause heavy bleeding. So not the postcoital bleeding, that's false. So adenomyosis false, atrophic vaginitis true, cervical ectropion true, granulosa cell tumor false, subserosal fibroid false. The next question, causes of chronic pelvic pain. What do you understand by chronic pelvic pains? The lower abdominal pain may be associated with menstrual bleeding or may not associated with menstrual bleeding. Lasting for more than 6 months is chronic pelvic pain. So the pelvic pain which could be or could not be associated with menstrual cycle lasting for more than 6 months called chronic pelvic pain. So what could be the reason? So the reason could be gynecological causes or non-gynecological causes. So the gynecological causes, any condition which can cause dysmenorrhea like pelvic pathology, like pelvic inflammatory disease, chronic pelvic inflammatory disease, adenomyosis, right? Endometriosis, previous gynecological surgery which cause adhesions. So now it can cause pain. Or some urological causes like bladder pain syndrome, right? Or maybe an alimentary canal like irritable bowel syndrome, inflammatory bowel diseases. Or maybe a neurological causes which can cause pelvic pain. Or maybe a spine problem, so orthopedic causes. So whatever the cause, they didn't ask the gynecological cause, whatever the causes which can cause chronic pelvic pain. Pelvic inflammatory disease, yes, of course, because the inflamed pelvis can cause pain. If it is chronic for 6 months, yeah, of course, they can have chronic pelvic pain, that's true. Endometriosis, yes, presence of endometrium outside the endometrial cavity which can cause inflammation outside. Like adenomyosis, which can cause chronic pelvic pain. Pelvic congestion syndrome, true or false? I'll explain this if you don't know. Pelvic congestion syndrome, true or false? Can it cause chronic pelvic pain? Fantastic. Thank you very much for answering. Pelvic congestion syndrome can cause chronic pelvic pain. So what do you understand by pelvic congestion syndrome? What you understand by pelvic congestion syndrome? Anyone? Yeah, of course. Here, like the varicose vein, this ovarian venous flexus or maybe a pelvic venous flexus are getting congested due to valvular issues. So, like a same as your ovary, so this varicose vein. So, due to congestion, patient will have severe pelvic pain. So, in history, you can simply diagnose this pelvic congestion syndrome will improve when the patient is lying down. Because the ovarian vessels will drain when the patient is lying down. When she is in stand-up position, blood will accumulate around the uterus and the ovary, and which can cause pain. During the menstrual cycle, uterine and ovarian pelvic blood flow will increase, so congestion will high and they will have severe pain. So this pelvic congestion syndrome might increase during the menstrual cycle, and which can last in between menstrual cycle as well. And it will reduce by lying down, so which can cause chronic pelvic pain. So then the treatment, what we do to either you can give OCP, because when you give the OCP, the ovulation will stop and blood flow to the pelvis will reduce. Yeah, that is one. Second thing, you can do THBSO. Once you remove the uterus and ovary, everything, the venous flexus will not drain there, so then pain will release. So pelvic congestion syndrome, it's true. Intestinal cystitis, true or false? Sorry, interstitial cystosis. So interstitial cystosis is the other name is bladder pain syndrome. Yeah, which can cause chronic pelvic pain. That's true. Constipation, yeah, of course. But this is quite doubt because they haven't mentioned whether constipation is a chronic constipation or acute constipation. When they mention blindly constipation, it's a bit of doubt. Better you can leave it in your exam. But chronic constipation can cause chronic pelvic pain, but acute constipation, no, it won't cause chronic pelvic pain. So better to leave it if when you have the exam, question like this in the exam, because it's a bit doubtful. We don't know what the examiner are giving as the answer sheet. Right, okay. Question number 4, uterine leiomyoma. What do you understand by uterine leiomyoma? What is uterine leiomyoma? What is uterine leiomyoma? Very good. Uterine fibroid. So the uterine fibroid is over proliferation of myometrial tissue which forms mass. It's a benign mass, very, very rare to become malignancy. This mass does not have any capsule around the mass, but you can easily differentiate this mass and the normal tissue. That's why we say that plane is pseudocapsule, right? So when it is a uterine mass, which might prevent the uterus to contract, so which can cause heavy bleeding, and which can cause subfertility, which can cause mass, which can cause compression. So I will teach you about the uterine mass in another class. So we'll do the question. So are frequently seen in teenage. That is false, because uterine fibroids are common in 30s and 40s, not in teenage. Right? It's false. Are familial. That's true, because uterine mass or fibroid, it's common among the family members. Yeah, that's true. Uterine leiomyoma cause oligomenorrhea. So you need to know what will happen if it is a fibroid in the uterus. So mostly this uterine fibroid will cause menorrhagia, heavy bleeding, than oligomenorrhea. What do you understand by oligomenorrhea? Oligomenorrhea is a less number of small amount of bleeding rather than the heavy bleeding. What are the reasons for the heavy menstrual bleeding in fibroid? There are several reasons. One, when there is a uterine mass, what will happen? To feed the mass, new vessel formation will occur in the uterus, neovascularization, which can cause heavy bleeding. Second, when there is a mass during the menstruation cycle, uterus will start to contract to arrest the bleeding. But this fibroid will inhibit the uterine contraction. So uterus will not contract effectively. So bleeding will be a bit high. Third one, when there is an underlying mass which can increase the surface area of the endometrium. So when endometrial surface area increase, amount of endometrial shedding off will high, then bleeding will high. So there are several reasons this fibroid can cause heavy bleeding rather than oligomenorrhea. Around 40 to 50% of mothers could be asymptomatic, but among the symptomatics, they will have heavy bleeding. Fibroid will not cause oligomenorrhea, maybe an asymptomatic or maybe heavy bleeding. So, uterine leiomyoma cause oligomenorrhea, that's false. It's usually heavy bleeding. Uterine leiomyoma associated with endometriosis, false, because endometriosis is presence of endometrium outside the cavity. In uterine leiomyoma, it's problem in the myometrium, not deal with the endometrium, so it's false. Regress after menopause, what do you think? Leiomyoma regress after the menopause, true or false? Yeah, that's true, because these fibroid mass are growing under influence of estrogen. So these are estrogen dependent. So in the absence of estrogen, this mass will undergo apoptosis and necrosis. So this fibroid size will regress. So how do you call this regression after the menopause? How do you call the regression process after the menopause? Anyone? Yes. White degeneration or hyaline degeneration. Degeneration. Not regeneration. D means it's destroying. So these fibroid mass will degenerate in the absence of estrogen. So regress after menopause, of course, after the menopause, estrogen level will come down, so those mass will regress. Yeah, that's true. So answer for question number 4. Are frequently seen in teenage, false. Familial, true. Cause oligomenorrhea, false. Associated with endometriosis, false. Regress after menopause, true. Right. The next question is external cephalic version. So what you understand by external cephalic version is turning the baby to cephalic presentation from the outside for a breech presentation or maybe a transverse line. Because if it is a breech or transverse, you can't go for a vaginal delivery. So you need to turn the baby's head to lower pole to make it cephalic presentation to facilitate the vaginal delivery. So what we do, we are just turning the baby to cephalic presentation from the outside with the force. That is called external cephalic version, which can be done after excluding all the contraindication for vaginal delivery. Say, for example, if it is lower segment fibroid, baby's head might not be in the lower pole, so baby's head might be in the upper pole. So if it is a lower segment fibroid, can you go for a vaginal delivery? Is it possible? No. Then we are not going to do the ECV. If it is a placenta previa, will you do the ECV? Because placenta previa, it's not a indication for vaginal delivery. We can't do vaginal delivery. Past 2 cesarean section, can you do ECV? No, because we are not going to do vaginal delivery. So our aim of ECV, external cephalic version, is to facilitate the vaginal delivery. So wherever any contraindication for vaginal delivery, it's contraindicated for EGV as well. Agree that? I will agree that. So then other thing, the timing of EGV. Because if you do the EGV bit early in preterm, 34 weeks, 35 weeks, until 36 weeks, baby will move continuously. Even after you turn the baby might turn back to breech again. Reversion risk is high. But for the primary mothers, usually baby will engage by 36 weeks. For the multiples, baby might engage after 37 or maybe with the labor, a bit later. So if the breech engage into the pelvis, then you can't turn easily. Or with increasing period of gastration, the lico volume will reduce. So then it's difficult to do EGV. So that's why what we do EGV by 36 weeks for primary and 37 weeks for multi. When you do EGV, around 50% of chance to have successful EGV. 50% you might fail. Even if you are success, 5% of babies can reversion, can undergo reversion, can turn back to breech, even after successful EGV. Out of 50, 5% can turn back to breech again. If EGV failed, among the failed babies, 5% of babies can turn back to cephalic presentation spontaneously. When you do EGV, membrane might rupture, cord prolapse risk is high, cord might get compressed, fetal distress risk is high, risk of cesarean section. When you are turning, you might damage the uterus, uterine rupture is there. So there are so many complications with EGV as well, and patient will have pain as well. So when you do the EGV is success, then you can do CTG to check whether baby is doing good. If baby is doing good, you can send the patient to go home and deliver vaginally. So here the question is, external cephalic version should be performed under general anesthesia. It's false. EGV will be done as an outpatient procedure in the clinic, or maybe admit the patient and do and send her home. So not with EA. When the patient is awake, it's false. Does not affect the incidence of breech delivery. It's false, right? Because when it is, it's true because incidence of breech delivery, it's, so how many breech presentation is, does not affect incidence of breech delivery. What do you think, true or false? It's false. It won't affect the incidence of breech presentation, but it is affecting the breech delivery because you are turning. So when you turn, 50% of time, you are changing to cephalic presentation. So breech delivery incidence is reducing. So does not affect incidence of breech delivery, false. It will reduce the incidence of breech delivery. Carries a risk of uterine rupture. Yeah, of course, I have explained which can increase the risk of uterine rupture, but minimal risk, but it's there. Is successful in over 90% of attempts. No, I told you it's 50%. It's false. Should not be attempt in RH negative woman. False. You can do, but while you are doing an EGV, there is a chance of fetal-maternal hemorrhage, so you have to give Rogam to prevent the sensitization. Right? Should not be attempt in rhesus negative woman. It's false. We can attempt. So answer for question number 5, should be performed under general anesthesia, false. Does not affect incidence of breech delivery, false. Carries risk of uterine rupture, true. Is successful over 90% of attempt, false. Should not be attempt in rhesus negative mother, false. All right. Then the final question is the features of abnormal CTG in early labor. So actually I can't teach you entire CTG features because it's a big topic. It is not easy as you think to teach within a short period. I will do the CTG class as separate, so you all can watch it in the Maura, either theory or Viva, because both I have done in the theory under emergency topic and Viva, emergency Viva topic, you can see. So the CTG, when you comment about the CTG, there are 4 features we are commenting. One is baseline, second one is baseline variability, third one is acceleration and decelerations, right? So the baseline should be in between 110 to 160. If it is less than 110, that is called bradycardia, fetal bradycardia. If it is more than 160, that is called fetal tachycardia. Variability means the fetal heart rate is fluctuating like this, not a straight line. So this fluctuation should be more than 5 beats per minute every second. If it is less than 5-second fluctuation, that is called reduced variability. That could be due to fetal hypoxia. So the maximum fluctuation should be less than 25. If it is more than 25, that is called saltatory pattern. That is also suggestive of hypoxia. So you can identify whether baby is hypoxic or baby is doing good with this variability or reduced variability or increased variability, baseline, whatever. And the acceleration, what is acceleration? The baby is having increased heart rate by 15 beats per minute and lasting for 15 seconds. That is a good sign, because when the baby is moving, you will get an acceleration. So if you get an acceleration, that means baby is moving. If the baby is moving, what is the meaning of that? Baby is having enough oxygen. If the baby is starving, do you think baby will move? No. When you sleep now, so when I'm starting the class, you are answering very fast. Now the rate of answering is coming down. Why? Because you are sleepy. Maybe you might be hungry. So when your energy level goes down, then your activity will less. But still, if you are very active, what is the meaning of that? You are getting enough energy, enough oxygen, enough nutrition. So if you get an acceleration, it means baby is moving. If baby is moving, that's indirectly telling to you baby is getting enough oxygen and nutrition. So accelerations are good markers of CTG. And deceleration means the fetal heart rate dropped by 15 beats per minute and lasting for 15 seconds, which is, what is this? This is indicative of fetal hypoxia. So there are 4 types of deceleration. One is early deceleration, late deceleration, variable deceleration, and prolonged deceleration. So what is early deceleration? When the uterus starts to contract, the heart rate is dropping, that is early deceleration. So uterine contraction and deceleration is same, that is early. After the uterine contraction, if the baby's heart rate drops a bit later, that is called late deceleration. So sometimes some CTG might have early deceleration and late deceleration mixture, that is called variable deceleration. And the fourth one is prolonged deceleration. What do you understand by prolonged deceleration? The deceleration is continuing for more than 3 minutes. It means continuously baby has hypoxia. Maybe placental abruption. Baby's placenta has separated. Baby is continuously hypoxic. So heart rate dropping. Finally, baby will die. Cord prolapse. So baby is getting hypoxia continuously and baby will die. Uterine rupture. Baby is getting hypoxia, baby will die. So these are the causes for prolonged deceleration. So if it is a reactive CTG or healthy CTG, then that CTG should have certain features. The baseline should be in between 110 to 160. Variability should be between 5 to 25. There should be acceleration. There should not be any deceleration. Then only you can say it's reactive CTG. Baby is doing good. Now they're asking the normal CTG, baseline heart rate 150. So if the baseline heart rate 150, is it normal feature or abnormal feature? It's normal. I told you in between 110 to 160, it's normal. So this 150 is in between that. So it's normal, true. Variability of 5 beats per minute. That's normal, because I told you 5 to 25 is normal. So it's 10, it's normal, true. 2 acceleration in 20 minutes. Actually, there should be 3 acceleration in 20 minutes, but 2 acceleration, you can't say it's abnormal. We have to say it's normal. It's true. Deceleration at the end of U-turn contraction. When the U-turn contraction finish, the deceleration start. So how do you call this contraction? Deceleration? When the U-turn contraction finish, deceleration start. Very good. It's late decelerations. The deceleration occur a bit later. So any kind of deceleration, it's an abnormal feature. I told you. So they're asking, sorry, the features of abnormal CTG, right? So sorry. So features of abnormal CTG. Baseline heart rate 150, it's false because that is a normal feature. Variability of 10, it's false because that is normal feature. 2 acceleration in 20 minutes, false because that is a normal feature. Deceleration at the end of U-turn contraction, that's true because late deceleration is an abnormal feature. Sinusoidal pattern. What do you understand by sinusoidal pattern? Sinusoidal pattern is like a sawtooth appearance, right? So the symmetrical fluctuation is a special feature usually which occur in fetal hypoxia or fetal anemia, ruptured vasa previa, twin transfusion syndrome. So in that case, fetal anemia will have symmetrical sinusoidal pattern, sawtooth appearance. So if it is a sawtooth appearance, always you have to think fetal hypoxia or fetal anemia. So could it be a normal finding then? If it is due to fetal anemia or hypoxia, could it be a normal finding then? No, it's false. So sinusoidal pattern, it's abnormal finding. So features of abnormal CTG in early labor, sinusoidal pattern, true. So answer for question number 6, false, 2. Right, I think we have 12 questions and we have done those 12 questions. So I hope you might enjoy this session. So if you have any question, I can answer. If not, we can sleep. Do you have any questions? Okay, so then we'll have a nice sleep. Yeah, thank you, Sna. Okay, so then thank you for attending. I will inform you the next class. Have a good night. Thank you.